Welcome to Podium Perspectives, powered by Vaniam Group.
Welcome to Podium Perspectives, Advances in the Treatment of Breast Cancer, SABCS Highlights, a new podcast that shares up-to-date insights across oncology and rare disease. I'm Dr. Virginia Kaklamani, and I'm excited to start this series with my colleague, Dr. Neil Iyengar. In today's episode, Vaniam Group has brought us together to discuss updates from SABCS 2025 on breast cancer.
Great. Well, let's dive right into the data. Lots of really exciting data, some practice-changing data as well. So let's start in the adjuvant setting, and this is perhaps one of the headliner studies that we heard at San Antonio was the lidERA trial. And just as a quick recap, this was essentially a trial testing the oral SERD giredestrant versus standard of care endocrine therapy in the early stage setting. This was in patients with ER positive, HER2 negative, stage 1 to 3 breast cancer determined to have medium to high risk of recurrence. And ultimately, what we saw here was an invasive disease-free survival benefit with giredestrant over standard of care endocrine therapy, specifically aromatase inhibitor or tamoxifen, with a hazard ratio of 0.7. So I would say really a significant results here that ultimately and potentially position giredestrant as a new endocrine therapy treatment for patients in the early stage setting. We also saw what I would consider to be a manageable and favorable toxicity profile, although the most common AE was arthralgia, which is what we commonly see with aromatase inhibitors as well. But I think it was favorable to see low rates of discontinuation with giredestrant, which may reflect the manageable nature of the adverse effects. So, Dr. Kaklamani, I'd love to get your thoughts and insights into what you make of this trial and whether you think that this is something that might be practice-changing. How will you adapt this to your clinical practice?
So this is 25 years in the making, right? The last adjuvant trial that led to approvals, ATAC and Big 198, those were almost 25 years ago. So this is exciting. First line or adjuvant single agent endocrine therapy instead of giving a combination with a CDK4/6 inhibitor, which has a much less favorable toxicity profile, I think is big news. So the question is, who are we going to give this approach to? Who are we going to give a CDK4/6 inhibitor to? This trial included stage 1 higher risk patients, whereas the CDK trials did not. So definitely this patient population, even though it's a small subset, I think is relatively clear that giredestrant should be considered. And then when we're really competing or comparing the CDKs with giredestrant, we have longer follow-ups with the CDK4/6 inhibitor trials, so I probably would favor those. But as you mentioned, the toxicity profile, it can be a limiting factor to giving a CDK4/6 inhibitor for 2 to 3 years. So I think that's going to be one of the issues that we're going to be faced with. Now, one thing with arthralgias, I was thinking about that because I've used these agents and they seem to be a little bit milder compared to aromatase inhibitors. But one thing to keep in mind is around 15 to 20% of the patients on the trial received tamoxifen. So I wonder whether that addition of the tamoxifen was what led to relatively similar adverse events when it comes to the bone issues, and maybe we'll see in practice that giredestrant might be a little bit better tolerated.
Yeah, it's a really interesting point. I share a similar experience with the oral SERDs. I tend to see a pretty favorable tolerability, and I would say anecdotally, at least in my experience, less arthralgia or more manageable, as you've said. So I was a little surprised to see that in the trial, but I think that's a really interesting point about the tamoxifen as well. And I like that you raised the CDK4/6 inhibitor because, this is a question that I think was asked in the lecture hall at San Antonio about, what do we do about the CDK4/6 inhibitor? This trial, of course, was not designed with a combination of the CDK4/6 inhibitor. There are other adjuvant trials that are testing oral SERDs with CDK4/6 inhibitors. although many of those have a switch approach, right? Start with the AI and then move to the oral SERD. I think this is really the first trial, of course, to report out a CD or a oral SERD, but also one that where you start right off the bat with an oral SERD in the experimental arm, which I thought was really interesting. So, yeah, I'm very excited about this potential new approach, and I think it might be a more tolerable approach for our patients in the adjuvant setting. So, should we move to the metastatic setting?
Yeah, so here we have a plethora of trials and plethora of trials the whole year, not just SABCS, but let's discuss a few of them in the same context. So we have Ember 3, we have Elevate, we have Avera, and Victoria 1. And so we're looking at, again, oral SERDs in combinations or single agent. Ember 3 had some overall survival updated results that seem to be very favorable. Now there's a trend to an improvement of overall survival with imlunestrant compared to standard of care endocrine therapy. The combination arm of imlunestrant and abemaciclib seems to be doing pretty well as well. Elevate, we have elacestrant in combination with both everolimus and abemaciclib. Each one of these combinations producing a pretty impressive median PFS of anywhere between 8 to even 14 months. So I think that those combinations seem to be a nice strategy. Avera, giredestrant again, now with everolimus, outperforming the standard of care plus everolimus arm. So yet another combination of an oral SERD that seems to be very favorable. And then finally, Victoria 1, which is a triplet or a doublet with gedatolisib, which is a new PI3 kinase inhibitor, but more than that, because it looks at PI3 kinase, it looks at AKT, mTOR, and so forth. And when you combine that with fulvestrant and palbociclib, or just with fulvestrant, it outperforms the standard of care arm. So, Dr. Iyengar, you have all of these options in the metastatic setting. I'm assuming that your first line therapy, at least now, is pretty similar in most patients. You're going to give a CDK4/6 inhibitor plus endocrine therapy. How do you decide what your second line therapy is going to be?
Oof, that's the $1 million question, right? And I love that we have all of these, or will soon to have, hopefully, all of these options available to us. But it certainly makes things more complicated in terms of treatment selection. I think a lot of us are thinking about, essentially either a precision medicine driven approach, right, where we think about the mutational profile and selecting either a PI3 kinase inhibitor or AKT pathway inhibitor, or a SERD in the setting of a AKT pathway alteration or an ESR1 mutation, respectively. And certainly, you mentioned Elevate and combinations of these approaches for our patients with dual mutations. Versus, we saw some interesting data from Ember 3 with the combination, as you pointed out, the combination of abemaciclib with imlunestrant, and there we saw activity across the genomic landscape, which I think is very attractive as well. And we can see that as well with mTOR inhibition, especially with the gedatolisib approach that you mentioned, where we're actually inhibiting basically everything, right? Especially in the triplet combination, CDK4/6 inhibition, mTOR inhibition, AKT pathway inhibition. So ultimately, I think it's going to be a couple of things that come into play. One is I would still consider the genomic landscape and thinking about selecting targeted therapies driven by the mutational profile. The second piece, I think, is it is, I think, very important to keep in mind the study populations for each of these trials. There are differences in terms of patients who were previously exposed to CDK4/6 inhibitors. There are differences in terms of number of lines of therapies. So, I know we always say this to be careful about cross-trial comparison, but I think in this setting, we actually really need to be careful. And when folks are looking at those median PFS levels, we should really be asking, what are the differences in those study populations? And so just a cautionary note about selecting based on just looking at the PFS numbers or hazard ratios. And then the third piece I really think comes down to shared decision making. These agents all have different toxicity profiles, different schedules, different routes of administration. Gedatolisib, as you pointed out, is IV. In that triplet arm, patients are getting IV, PO, and IM therapy. So all routes of administration. So I think we need to discuss this with our patients, and that'll also guide treatment selection. I hope that's not too vague, but I think it really highlights the points that we could focus on, those three, to guide treatment selection.
I think the vagueness just highlights the fact that these trials have different patients, that there's more than one approaches, and we have to be very, very specific based on the patient we have in front of us. And as I think you mentioned, there's definitely a place for monotherapy, giving imlunestrant or elacestrant in patients that have tumors that have developed an ESR1 mutation. We all like better outcomes, and so when we look at all of these combination arms, it's kind of impressive that these combinations are producing much higher PFSs than the single agent. So I feel that once they get approved, we'll likely use more combination than single agent, but we cannot forget our single agent. And my concern, as I think yours is with gedatolisib, is not just the IV administration, but also the stomatitis. There are a lot of patients on the trial that had stomatitis. Unfortunately, we couldn't mandate steroidal mouthwash in that setting. So we'll have to see in practice how bad stomatitis is, because that's definitely an adverse event that is very troublesome to patients.
Yeah, absolutely agreed. How this plays out in the real world in terms of AEs, I think is going to be really important. So, in addition to the really excellent summary you provided of all of those trials in the ER positive space, we also saw data in the HER2 positive space, and particularly in the maintenance setting. And I think it's really great to start seeing all of these maintenance strategies coming through the pipeline here. So, of course, we previously saw data from the PATINA trial, which was essentially testing the addition of palbociclib and endocrine therapy with fulvestrant to HER2-directed therapy with dual antibodies, Herceptin and pertuzumab, after patients had gotten essentially an induction regimen with essentially the Cleopatra approach, taxane HP. And, we previously saw that really impressive progression-free survival, median progression-free survival of about 44 months, which I think was something that we were all really happy to see, because, of course, that maintenance period is a time where our patients start to feel more like their normal selves. So extending that's exciting. At San Antonio, we saw some additional data out of PATINA, which looked at CNS progression. And I think it was really interesting to see a hint here. I should actually make note here that CNS progression was a pre-specified secondary endpoint in PATINA. So there is, this is I would consider to be a robust secondary endpoint in PATINA. And the incidence of CNS progression or death was improved. And this was seen in patients without baseline brain metastases. So ultimately, these findings suggest that perhaps the addition of palbociclib to the maintenance setting may help to delay or prevent CNS involvement, although we need longer-term follow-up, to validate these initial findings. So, I think this is really interesting, and we compare that to the backdrop of Cleopatra, where the rates of CNS progression were higher than what was recently reported in PATINA with the addition of palbociclib. But speaking of CNS progression, we also saw results from the HER2CLIMB-05 trial, and these were the primary results that were announced here. So this was also a maintenance strategy after induction chemotherapy with the Cleopatra approach. But in this setting, patients received tucatinib, the TKI, with Herceptin and pertuzumab, with or without endocrine therapy, depending on their hormone receptor status. And ultimately, we also saw an extension in progression-free survival with the addition of tucatinib to the maintenance setting. And CNS progression-free survival was actually not reached yet in this initial reporting. And so ultimately, I think what we see here is that we see improvement when you add these agents, whether it's palbociclib or tucatinib, to the maintenance setting. Of course, PATINA focused on the hormone receptor positive group, whereas in HER2CLIMB, it was HR positive or HR negative. And ultimately, I think that hormone receptor status may help guide which approach that we choose, but certainly considering the CNS activity, we certainly know that tucatinib has CNS activity. And so I think that's a factor in deciding which approach to take in the maintenance setting. But I will say that the patina PFS was really impressive. And so for my hormone receptor positive patients that are also HER2 positive, I'm inclined to use that approach. And for our hormone receptor negative patients, now with the HER2 CLIMB-05 results, I think adding tucatinib is an attractive approach as well. But of course, we have to interpret all of this in the backdrop of DESTINY-Breast09, which we now know has recently been approved. So we now actually have TDXD, trastuzumab deruxtecan plus pertuzumab, as a potential option in the first line setting as well, in addition to the Cleopatra plus maintenance approach. So, Dr. Kaklamani, what do you make of all of this? I mean, we were talking about all the options in the HR positive space, and now we're starting to see this in the HER2 positive space as well.
This to me is more clear. I can combine all of these trials and package them into one thing. And so what I will probably do is start with the Destiny Breast 09 and give TDXD plus pertuzumab to my patients. Do that for 6 to 9 cycles or to maximum response, something like that. And then obviously toxicity is going to be an important guide here. And then switch to a maintenance approach. And that maintenance in the ER negative would be tucatinib, in the ER positive would be palbociclib and endocrine therapy. And I think that way we can get a lot out of that first line therapy. If we see progression of disease, we can add TDXD or switch back to TDXD. And I think that way that first line will be extended to a lot more than what we're seeing in these clinical trials. And I feel that the toxicity profile will be more favorable. So the last thing I wanted to talk about was the wisdom trial. And this is exciting because now we're switching to screening. And instead of just having 20 different guidelines and confusing our patients about how to screen, when to screen, what the interval is between screening mammograms, to really have a more risk-based approach where we take patients, we stratify them based on their risk, which includes models that have genetics, breast density, and so forth. And then we have 4 risk categories. The lowest, where we don't do screening until the age of 50, the average, where we do biannual mammogram, the elevated, where we do annual mammogram and consultation with a breast specialist, and then the highest, where we add MRI. And this was an important trial, a huge effort that showed that with this screening approach, we do not increase the number of stage 2B cancers or higher stages. And so this is very feasible. It probably will help with the economics of our healthcare system, and at the same time, probably decrease the stress and really give women what we've always been thinking about, not just put everybody in one bucket, but really stratify them based on risk. So Dr. Iyengar, quickly, you're looking at wisdom. How would you counsel individuals coming to you without a diagnosis of breast cancer?
Yeah, I mean, that was such a nice summary, and I think certainly Dr. Esserman and the Wisdom team are really to be commended because doing prevention and screening trials are so challenging. I like this approach a lot because the categories that you described and that kind of risk-driven approach, I think, really helps to not only decrease perhaps unnecessary imaging and perhaps exposure to unnecessary biopsies and so forth, but really also helps to escalate screening in our highest risk patients. And so I know that this is currently the subject of much debate amongst the field and amongst professional societies because there are a lot of guidelines with regard to breast cancer screening. So we'll have to see how this plays out in terms of the current guidelines for breast cancer screening. But I do hope that this gets incorporated in some fashion because we need this type of risk stratification to optimize the experience for our patients. So with that, we just went through a whirlwind of data here, and I want to thank you, Dr. Kaklamani, for this fantastic discussion, and thanks to all of our listeners for listening to this first episode of Podium Perspectives.
And please follow and share to stay current as new data come out. This episode is for educational purposes only and is not medical advice. So see you next time.
Thanks for joining Podium Perspectives, powered by Vaniam Group. This episode is for educational purposes only and is not medical advice.